This is week 12, prenatal diagnosis of chromosome abnormalities, part 1 review. The learning objectives for this week are to review pedigrees, review syndromes, to describe the diagnosis of microdeletion syndromes identifiable using molecular technology, including fluorescence in situ hybridization FISH analysis or array comparative genomic hybridization CGH, and to discuss advantages and limitations of molecular karyotyping in prenatal diagnosis. I want to start off by looking at some pedigrees and some questions about pedigrees. The first one is a normal male and a female who is homozygous for an X-linked recessive disorder are planning on having children, and of the offspring that they may have, it is probable that A, no sons will be affected and all daughters will be carriers. B, all sons will be affected and all daughters will be affected. C, all sons will be affected and all daughters will be carriers. D, all sons will be affected and 1/2 the daughters will be carriers. The answer is that all sons will be affected and all daughters will be carriers. What is the probability that an offspring of an affected person and an unaffected person with an autosomal dominant disorder will be affected? A, 1/3, B, 1/4, C, 2/3, D, 1/2, or E, virtually 0? The answer is D, 1/2. That's because children are either affected or unaffected. What proportion of all offspring are affected females if the father is affected with an X-linked recessive disease and the mother is a carrier of the same disease? A, 25%, B, 100%, C, 75%, D, 50%, and E, virtually 0. The answer is A, 25%, or 1/4. And that is because it is 1/2 of a chance that you could have a daughter, but it's going to be 1/2 that they will have the disease dependent upon whether or not the mother gives her defective X or her normal X. So 1/2 times 1/2 is equal to 1/4. Read the question very carefully when it's referring to the girls and not just children. What is the probability of having an affected child if one parent is affected with an autosomal recessive disease and the other parent is a carrier? A, 1/2, B, 2/3, C, pretty close to 100% because new mutations are frequent, D, 1/4, E, virtually 0. The answer is A, 1/2. That is because an individual that has the disease, the autosomal recessive disease, is 1. We know they have the gene. You multiply it also by the known carrier is 1. But dependent upon whether or not the carrier gives the defective gene or the normal gene, you multiply by 1/2. So it is 1 times 1 times 1/2, which is equal to 1/2. Now let's do a little bit of syndrome review because, as I said before, we need to be able to answer questions on our syndromes as well as pedigrees quickly and to understand them and to be able to recognize them. So I plan on, for the rest of the semester here, I plan on giving you pedigrees and syndromes and probabilities review along with other material. In this first case, we have a child with short stature, learning disabilities, transient neonatal hypercalcemia, supravalvular aortic stenosis, and an elfin-like face. This child has Williams syndrome. It is a deletion in chromosome 17, q11.23 in most cases, and it can come from either parent. The elfin face, if you look at the mouth, the ears, the shape of the ears, and the nose. This is a characteristic looking child with Williams syndrome. In the second case, we have hypotonia, hypogonadism, extreme obesity with hyperphagia, a distinct face, short stature, small hands and feet, mild developmental delay, and a learning disability. And when you hear that, what do you think of? You think of Prader-Willi, a deletion in chromosome 15q12 in most cases. It comes from the father. Remember, in the female, if it came from the female, it would be Angelman syndrome. In the next case, we have learning difficulties, macroencephalia, long face, large ears, macroorchidism. This is Fragile X, caused by a triplet repeat mutation in FMR1. This is a characteristic facial features in someone that has Fragile X, and the face becomes more elongated as an individual matures. Here we have hypoparathyroidism, hypoplastic or absent thymus, congenital heart defect, and facial dysmorphism. This child has DeGeorge syndrome, a deletion in chromosome 22 at the Q11 spot in some cases. Either parent can cause this. And the last one, it's micrognathia, posterior displacement of the tongue, cleft palate, and defects of the eyes and the ears. And the answer to this one is Pierre-Robin's sequence, and it is a de novo mutation in most patients. This is a very characteristic looking child who has Pierre-Robin sequence.